Okay. Hello, everybody. We are here again from São Paulo, Brazil, specifically Dante Pazanese, Institute of Cardiology. It's our pleasure to be with the MedStream 360, and I also like to emphasize how much grateful we are to be part of this excellent view of teaching and live transmission and doing cases that our routine case. So thank you, Samir, again for this great opportunity to be with you in this exciting program. So we are here in the lab one. I have here Dimitri again, as you know. I know you have talking about Dimitri, our director from structural heart disease. We have Alberto Cervoni, Dimitri Siqueira. Alberto Cervoni is just in his left. He's going to be the first operator in this. And we have Michele, our 50-year fellow in structural heart disease at Dante. So we have two cases to present today. The first one is going to be here. It's going to be a structure, as you can see in the slides. Dimitri is going to present that. And from here, after we finish this case, I'm going to move to lab 4, where we have a coronary case. They are in the routine. They were scheduled for today at Dante Pazanese. Okay, Dimitri, please.
Okay, Fausto, thank you. Hi, everyone from MedStream. Uh, Let me present our case for today. This is a 81-year-old female, not frail, but she is a small lady, Fausto,
Hmm.
with 88 kilos, um, and her body surface area is 1.9. So, and she has also a small annulus. So she is a little bit of risk of
Hmm.
patient-prosthesis
Hmm.
mismatch. As relevant comorbidities, hypertension and dyslipidemia. She presented with symptoms of heart failure due to aortic stenosis. And on perioperative risk assessment, the EURO score 2 is 2%, and her STS is 3.9%. On lab tests, she has thrombocytopenia. The renal function is normal. The GFR is 69, and she has a high level of BNP 1,100. Here is the ECG with sinus rhythm, no conduction disturbance. And on echo, she has a tricuspid valve, very stenotic, with thickened and calcified leaflets. The peak gradient is 112. The mean gradient is 78 millimeters per mercury. And the aortic valve area was estimated as zero point 0.6 centimeters square. And she has also a preserved LV function with an ejection fraction of 64. And these are the CT findings. Maybe Alberto could go on what we found here.
Yes, of course. Thank you, Dimitri. So in the CT findings, we have an annulus diameter of 19 and 23, and a small annulus, as you told us before, smaller than 400 square millimeters. So her is 344. The valsalva diameter is 26, 26, and 27. So the LVOT is a small LVOT as well, from 18 to 22. The sphenotubular junction, we have extreme calcification, like 360 degrees of calcifications. The smaller diameter is 21. So the extending aorta is 26 to 29. The coronary heights are satisfactory, over 12. The implant view, the coplanar view, is 3 of ROA and 9 cranial. The angle is 35. For the femoral, we have small diameters in both sides, but the left one has less calcification, so we choose the left one to perform the TAVR.
Okay.
Okay. Uh, so this is the case summary. So 81 years old
Female, yeah.
female. So she has 88 kilograms. I was doing some calculations here in my mind. She's less than 1 meter and 50 centimeters. So that we mean that she has an
BSA of,
CMI
yeah,
almost at 35.
yeah, yeah.
So she's obese patient. Although she has small diameters,
Hmm.
she's obese.
Yeah.
That's very important. Non-frail, low surgical risk, anatomical challenge for TAVR, small annulus. So, and after heart team discussion, we decide for TAV.
Yeah.
Is that how do you decide here in our hospital a case like this? How can you convince the surgeon, or he is already convinced, not to operate this lady,
It's
or
yeah, it's
because it could
pretty,
be
yeah, it's pretty
operated?
standard how we select patients here at Dante.
Mhm.
We have a very active heart team.
Mhm.
Everyone is engaged, so we discuss about 5 to 8 cases a
Mhm.
week
Mhm.
in 2 sessions.
Mhm.
Uh, and in fact, patients above 70 or 75 with no anatomical challenges for TAVI, we are selecting those patients for transcatheter
So,
heart
in
implantation.
other words, we know the scores by STS or even EURI score that the patients are low risk for
Hmm.
this score. But when you mention the age, patients above 75,
Yeah,
the risk is not low.
yeah.
Do you agree with this assessment?
I agree for surgery,
Um,
but in fact, this is an octogenarian patient
um,
with large BAC
um,
and a risk of patient-prosthesis mismatch. So TAVI is a good option in those
and also
patients
the
nowadays.
extracorporeal machine,
Yeah,
the lung machine,
yeah,
heart-lung machine. That's still a problem for patients above 75
yeah,
years old.
yeah. That's
So,
true.
have you done echo? So you have the strategy. Before looking at the strategy,
Hmm.
let's talk to Andrea, who
Okay.
is from echo. And before Andrea, I would like just to present the excellent team of nurses. Can you open this our image here? If you can move the camera to my right here. Yes, you're going to see the excellent team of nurse. You can see Fernanda. Fernanda, say hello to everybody. Okay. We also, uh, Renata. Renata is here with us. And, uh, and we also have the anesthesiology. Now, if you move the camera now just to behind the, yes, over there we have uh, our anesthesiology, Walter. Hello, Walter. And also Andrea. She is the responsible for echo. She's just behind the camera. So if you look at our head now, we have a new cap here. And you can see Dante Pazanese. We just built this to everybody, and we have the names here. That's quite new. We are starting news today. That's going to be a good idea because I saw in some transmissions and I understood that it would be very important for us. Andrea, the words
Okay,
is yours,
thank you.
please.
I'm very happy to be here. So this is the echo about today in this patient. This is the apex view, and we have LV hypertrophic and stenotic and calcific aortic valve. We can see a point, a calcium point in LV outflow tract and the mitral annulus. In a short view, the patients don't have a good acoustic window, but the aortic valve is a tricuspid valve. In free chambers with color Doppler, uh, there no obstruction of outflow systolic in the LV outflow tract. There are mild aortic regurgitation. The ejection fraction about 3D echo, it's 5.9%. The main gradient today it's 88 millimeters mercury, and the LV area it's 0.47 centimeters square. This is the strain analysis, and here we have 4 chambers, 2 chambers, and 3 chambers. There are no um, uh, altered about segmental contractility, and the patient has good systolic function. Global longitudinal strain estimate about 20%. It's normal.
Okay, great. So, any additional comments, Andrea?
No, it's
Okay.
okay.
So thank you so much. Now, can you please bring the slides again? And I'm going to ask Dimitri about what is the strategy for today. Dimitri.
So we are going to perform this case with minimalist approach with conscious sedation.
Mm-hmm.
We're gonna use balloon expandable valve, and we're gonna implant this valve using wire pacing.
Mm-hmm.
So let me show you what we have done so far. Patients got a radio access for angiography and for
Can you
hemodynamics.
have the full screen, please? Just to show
As Alberto just said, we're going to use
the
the left
camera
femoral
in the
artery
room.
for TAV implantation. And one challenge here is to select the valve size because she has a small annulus. There is some calcification on the LVOT track. Maybe Alberto can show you some slides later um, regarding prosthesis selection
Yes.
and our strategy
That
here.
that would be my question. Are you worried about to have a complication in a case like this? We should always be worried about the maybe the most terrible complication that we can
Mhm.
have in those procedures. That's a rupture of the aorta.
Yeah, CT helps us a lot in predicting some complications. I think that the major challenge here is the small annulus.
Mm-hmm.
Uh, there's some calcification on the LVOT track, as I
Mm-hmm.
said before, but it's not a huge calcification, and we're gonna be very selective in terms of sizing on this patient.
Okay.
Good
Alberto,
access,
yeah.
no rhythm
Mm-hmm.
disturbance. So it's a pretty standard case of our daily practice.
Are you using the same uh, technique that you did the last time, trying to use only one per close?
Yeah, this is our standard approach nowadays. We always puncture the femoral with ultrasound,
Mm-hmm.
and we're gonna use just one proglide
Mm-hmm.
for hemostasis.
So you
And in about 70 to 80% of cases, we finish the case with just one
what?
proglide.
Okay, great. So you're not using a pacemaker wire. You're trying to use only one proglide.
Yeah,
So you're trying to do a very
simple
save cost,
and
simple approach,
safer
and
procedure.
save cost approach.
Yeah.
That's very important because everything that you can save, you don't waste the money. So
We already crossed the aortic valve,
yeah.
and Alberto now is placing
Hmm.
pre-shaped wire in the
What
apex.
kind is wire is this one?
So this is the confident wire.
Confident wire. Do you think there is any difference between sapphire and confident wire?
I don't think so.
No, so it's the same.
Yeah, pretty the same. I mean, you have different sizes with Safari.
Hmm.
Have the large, the small, and the extra small. In the majority of cases, we are using the
So,
extra small Safari.
Alberto, do you want to make some comments on how to choose the valve or anything that Dimitri said
Yeah,
about the case?
yes, thank you, Fausto. First of all, I will ask the Andrea to tell me about the wire position in the left ventricle. By the angel, it seems to be okay,
Okay,
but
good.
I want to
May
check,
you
double
have the
check that.
It's the
ultrasound in the screen,
Liquia, vê se
please?
o guia está bem posicionado.
Echo, just to check the position. Yes. Andrea, can you show us,
yes,
please,
sure.
the wire position in the LV
Yes,
apex?
it's the good position. The white wire, it's a apex LV.
This is an
Oh,
important step to
to
be
do intervent.
careful about wire position.
Yeah.
So we check on fluoroscopy
Yes.
and we check on echo. This patient has a small left ventricle. So
And like we did last time, you can see here is like to pilot an airplane.
yeah,
We need to be uh, exactly under the rules. So the first one, you have a stiff wire in the LV and a small LV. You need to make sure about the position, avoid any kind of perforation by the wire. Because when you are placing the valve, you don't want to have this kind of complication. Now
so
you brought the sheet in there.
yeah,
It was easily.
yeah. Alberto, just insert the
Okay, can you
sheet.
have the angel now, please? Angel in the screen, please.
Can you hold it?
Okay, thank you. Now you're fixing the
Yeah,
introducer
this
sheet.
is a very hydrophilic sheath. So it's wise to fix the sheet on the skin.
In the skin.
Just to make
And
sure
can you
it
close
doesn't
just
move.
what he is doing there in his hands, please, with the camera?
Okay.
Okay, great. If you can get closer, he's just fixing the sheet. It's very important to make the procedure more comfortable. And you know you cannot have the sheet moving. Is that correct,
Yeah,
Dimitri?
yeah.
So we have the wire under over
Okay.
the pigtail. We take the pigtail out and we introduce the sheet and we fix the sheet. And now, Alberto, what are you gonna do?
I think we can move on to the valve implantation. So I'll ask,
So can you tell us how to choose the valve?
of course,
Do you
can
need
you?
the slides?
Yeah, I do need the slides, but
Okay, may we have the slides and you talk. May we have the slides on the screen and Alberto, who is the first operator, talking about what we are gonna do.
so
First, are you gonna do a predilation?
no, Fausto. In this particular case, we are not doing the
Predilation.
predilation.
You're going director.
Yeah, we are going
Direct
directly.
implantation. Okay, go ahead, please.
So, as we told you before, we have a small annulus, we have a small calcification in the LVOT,
Uh-huh.
and we have the limit between the size of the valves. So
So
we
it's
choose,
a borderline
yeah, it's a
zone
borderline valve. So we choose
between.
based on area, the intermediate size, that's 21 and a half.
21.5. So
Yeah.
if you have a sapien trees, what size of valve would you use?
So you have to choose between the 21 with overfilled or the 23 underfilled.
Uh-huh.
So it's the operator decision.
So with the MyVal, as I understood, you're going to choose a 21.5.
Yeah, we use the intermediate
Is
size.
there any advantage in doing this?
Yeah, you have a more tailored approach for the patient. I don't know if it will reflect in clinical impact,
Outcomes, yeah.
outcomes, but it is a tailored approach for the patient.
Okay, good. What is next? To look at the valve?
Yeah, let's go. I'll explain a little bit of the THV characteristics.
Uh-huh.
So it is a balloon expandable valve that has intermediate size.
Can you take the valve and bring it? The valve is ready, Karina? Tá pronta?
Tá pronto.
Okay, can you bring it and you can talk about this
Okay,
with
of
the
course.
valve in the place. Okay?
Aqui.
So it is a balloon expandable valve, as you can see, that has intermediate size as a 21.5, 24.5, 27.5.
So if you can now close the valve here, please, with the camera and keep the slides. Closing now in my hands here. Okay, right here.
Yeah.
Okay,
We have extra large size, the 30.5 and 32, in addition of the traditional size of 20, 23, 26, and 29. It has a bovine pericardium leaflet with an anti-calcification treatment. We have an external PET puffing to minimize the incidence of PVL. It has a nickel cobalt alloy frame that gives a good radial extrait and a great head opacity. We inserted before the sheath, the Python sheath. It is a expandable sheath, 14 French expandable sheaths that is compatible with the all size of the THV from 20 to 32, but from 27.5 on, we have to pre-dilate with the dilator, 18 French dilator. The navigator system you can see here, it's a good, that has a good flexibility, and one single step, that's to do the deflection. Another great feature that the valve is crimped directly on the balloon, and it's able to retrieve in case of we cannot cross the annulus. So we have a radial opacity pattern that help us to position the valve in the annulus. So we basically use the second bands in the base of the pigtail catheter, and this positioning guarantees us at least 25% of ventricular positioning. So to move on,
Yeah.
I think we can check the valve positioning. We have to check it is an aortic position with the skirt distal in the navigator. And another thing we have to check is the volume in the
The inflator, right?
the insufflator.
We have 15 ml, 15 cc here.
So I think we are good to go. If you're okay, Dr. Fausto and Dimitri.
Yeah. So let's move on. Let's insert the valve here. Okay, Alberto, you can go ahead.
Okay. I will insert the loader with the delivery system, and then I'll go only with the delivery system.
Okay, you can go on. I'm holding the wire.
Yeah. It's an expandable sheath, so it has to expand. As you can see the fluoro marker there, when we reach with the prosthesis, it will be open. Now.
Okay.
So I'll take the loader off.
Alberto, how often do you usually pre-dilate when you're going to use MyVal?
Thank you, Dr. Fausto. In our experience, we usually pre-dilate about 30% of the patients.
30%.
We do not do routinely pre-dilation.
Okay.
We only pre-dilate in particular scenarios, like bicuspid valves, small area, or when we have doubt about the sizing.
Okay. So just before implantation, let's check the pacemaker. And I think we're gonna to reposition the pigtail also.
Okay.
Deixa eu pegar aqui.
Put it here, okay?
Vamos checar o marca-passo, Valtinho, por favor? Vamos ligar a 100. Pacemaker on. $120. Okay, looks fine. And
Good capture.
pacer off. Pode ligar. Reposicionar o pigtail.
Okay.
Let's reposition the
We
pigtail.
check the pacemaker now. Can you, that's okay. And now,
Okay, great. A bomba está pronta? Deixa a bomba preparada aí, por favor.
Now we are going to advance the valve.
Yeah. Let's do the deflection here.
Now it's deflection.
Okay.
Dimitri is doing this in his hand, and
I
Alberto
got the wire.
is advanced
Okay.
the valve, and Dimitri is holding the guide wire. Now it's close to the aorta. You're gonna see that.
Can I cross?
Yeah.
Yes.
Is okay for you? So let's go.
Okay.
Okay.
It was easy.
Yeah, really
Oh,
easy, Dr.
Quite
Fausto.
easy. I think we are in a good position.
Let's
You can
do
see
an
the
angel here. Just check
Valve
the
marks,
position.
the pigtail. Maybe you can describe, Dimitri, and the right position, and to show everybody how you do that.
Injeta.
Please.
Injeta.
Injeta.
Okay.
Dimitri, do you want to make comments about the position?
Yeah, we tend nowadays to implant this valve a little bit higher just to prevent conduction disturbance and pacemaker need.
That's
So
okay.
What is your reference, right?
sometimes we use RAO just to put the valve in a shallow position. We can make another angel here. Tá pronto aí a bomba?
Bomba tá pronta? Injeta.
Injeta. I think it's a good position, right?
Yeah, I think so.
Yeah. You think it's okay?
Yeah. Let's implant now. Marca passo,
What
tá
is your
pronto?
reference to position?
So
Maybe
we
you can
have-
tell the audience.
Can you see, Dr. Fausto, in the fluoro, we have a first dance band, a second light band, and a second dance band. Usually, we use the second dance band in the base of the pigtail catheter that give us the 25% ventricular placement.
Okay.
So let's
Good,
implant
good
the valve.
explanation.
Liga o marca-passo, por favor. 100.
Now the pacemaker. Can you have
Bomba tá
now
pronto?
the hemodynamics in the screen,
Deixa eu ver
please, if it's possible? Hemodynamics now.
180.
Hemodynamics,
Okay.
please. Okay.
Injeta.
So it's 180. We deploying the valve, as you can see there, inflating the balloon.
Furou o balão.
Desliga o marca-passo.
Deflated. Pacemaker off. And the blood pressure is back again. The heart rhythm is okay. And pull back the
Can I
balloon.
take on
And now we have Andrea checking with echo. Andrea, what are the main findings then you look for in the echo after we place the valve? Please, Andrea, what are you looking for?
We look in the short view to see the
Pericardial effusion.
to see the prosthesis
Balão
about
20 para mim. Abre
expansion.
balão 20. Abre balão 20.
And
Could you say again, please?
in the short view for about the prosthesis, about expansion, the prosthesis, and we put a color Doppler to look for a leak. And in this case, it's
So-
no leak. It's a very, very,
No regurgitation.
no, it's
No
very
regurgitation.
minimal
False.
regurgitation.
Can you have the
and-
echo in the large screen, please, now?
It's important to see the pericardial.
Yeah.
She don't have a pericardial effusion,
okay.
the
Fausto,
contractility, and the
Despite,
gradient.
Andrea, despite the good result on echo at this point, we noticed that the balloon ruptured during
Yes.
implantation.
Yes, I saw that.
Yes,
Look at that.
So let
I'm-
me
I'm saw that
repeat
too.
the angel here.
I saw that too.
It's like a calcified
I think
lesion in a
it's
coronary artery.
Yeah.
yeah.
So we're gonna use a 20 balloon just to make sure that the valve is expanded.
Okay. So we had the balloon rupture. Can you show the angel now, please, just to see when we expand the balloon and the rupture on life? Yes. Can you put the balloon, the movie, please? Play. Yes. If you look at this, I could see that. So now the valve is expanding with the balloon. So expanding, and then rupture, balloon rupture. Why did it happen, Dimitri? Do you have any
Maybe because
explanation?
of calcification.
Yeah,
The sinotubular junction was very calcified. It's
yeah.
a small anatomy.
Hmm.
So maybe we gonna check echo again
Hmm.
and decide if
If
this
you
patient
should,
need pulse
well,
dilation with a 20 balloon.
okay.
And maybe we can move to the another room just
Yeah,
to
let's
decide, and
see.
then
Yeah,
we can come back.
let's see. Maybe we can finish the procedure here. In 10 minutes, we'll
Hmm.
be done. So, do you
So
have any gradient? Can you
yes,
Okay,
we
can you bring back the echo in the screen?
the
The large screen, please. Now you can have only
this is the
the
gradient.
camera. Can you open the camera in the room with the operators, please? And Andrea is talking about the gradient.
The big gradient, it's 16 millimeters mercury, and the
Could you
main
say again,
gradient it's
please?
8.
8 millimeters.
The main gradient 8.
I mean the maximum or the
The
The mean
maximal
is
it's
8.
16. The maximal is 16,
thing and the
and the
median is
mean is
8.
8.
So you should maybe you should pose that later.
Yeah.
And Dimitri.
Let's do an angio first,
Hmm.
just to check how the valve adapted to the
Okay,
anatomy.
Can you?
Dimitri was
Yeah,
thinking
we are
in
not in
going.
a hurry. Patient is very stable right
Uh-huh.
now with
Yeah.
diastolic pressure of 65. So let's check on angio and decide if the patient needs a pulse dilation.
Okay, can you bring the angel in the screen now, please? The angel.
We are not questioning the what Andrea just saw, but
Vamos preparar, bom?
just to know how the prosthesis adapts
So,
to the anatomy.
is there any um, rule and about the gradient? What is the minimal gradient that you accept? Not to pose dilate.
Usually with neurogeneration THV, maybe the mean gradient is 6 or 5.
Okay. Now we have 8. It's a little bit
Inches.
above. Do you
Yeah.
think we should pose dilate?
Let's think about it.
Do you
Like I
balance?
said, there's no hurry. Patient is very stable. We're gonna check on angel
Okay.
also,
So
and
maybe we
maybe we
can.
can measure the gradients
Mhm. Okay.
before deciding.
Yeah. Maybe because we have 10 minutes here because we have a multivessel disease in the next lab.
Up
We are
to you,
gonna
Fausto.
finish.
If you want to move to
No,
another
no, no,
room and
no,
then,
no. We stay here up and to finish the whole procedure,
so
and
let's measure the
we go there.
gradient. So
Okay. Do you always have this kind of preoccupation and to do the post dilation?
yeah, yeah.
Yeah, I know that. I can feel
Pulse
that.
dilation is not 100% safe.
Hmm.
It's associated with risk of stroke, for example,
Aqui.
So,
and
and if you measure, you balance this, the mean gradient is about 8.
yeah,
You're gonna see now here.
that
So you have
there's a risk
no
risk
no
of a
no
pacemaker
regurgitation.
need. So
Yes, no regurgitation, and there
It's
are
a mild paravalvular leak.
mild,
Mild.
mild paravalvular leak. Okay, let's see what.
let's see the hemodynamics. It looks fine.
Uh-huh.
Looks very good.
Can you bring the hemodynamics, please, in the screen? Just in the big screen, the large
Vou
screen,
lavar, tá?
the hemodynamics, please. Great.
Peak,
Can you
peak.
have this in the large or is it okay? Great.
Okay, just
She
a
do
minute.
the
So peak gradient is
gradient
about
intra.
5 maximum
Hmm.
on hemodynamics, right?
You know,
Five,
if you
7.
ask my opinion, the patient is
She do
81 years.
gradient in output trapped.
Yeah.
It's better.
That's not so
Let's do an
large.
angel.
So the patient is 81. Now, can you bring the angel, please, in the screen? We are gonna do an angel. Just wait a little bit. Okay, we have the angel now.
Jetta.
Oh, yeah, no regurgitation. No regurgitation.
Yeah.
So, so the mean gradient is below 5.
The peak gradient is now it's around 8.
8, yeah.
and by echo is 8
Hmm.
millimeters. There's no aortic regurgitation. Um, I think we got a
If you
good
ask my
result.
opinion, I would stop. Do you agree, Alberto?
Yeah, I do agree. I
Yeah,
think we have a good
I think
result.
good results in echo, good results with the hemodynamics, no, just mild aortic regurgitation, and we cannot see in the angio. I would stop. Do you
Okay.
agree? So let's finish the procedures and show what we do here because it's very important. Now we are on live in 37 minutes to finish this procedure. We just start with the puncture and also the cross valve just to see the minimalist approach as Dimitri said.
Melhorou. Onde está a
And while we
pressão?
are doing this, Alberto, could you
A
describe,
pressão.
please, our experience with
A
MyVal?
pressão dela.
Okay, of course, Dr. Fausto. Our experience with MyVal, I think, is the biggest experience in the South America, Latin America. We have about 150 cases performed. We start since December 2020. The first case were performed here. We have a
Who
good.
did perform the first case? Do you know that?
You did.
Oh, it was me.
We
I
have
did
a
that.
good clinical
So
results.
almost 3 years, 2.5 years ago.
Yeah. Good clinical results, good hemodynamics, a low pacemaker rate, only one digit, and low PVL rate as well.
É, melhorou.
So, and how about the follow-up? Can you tell us about the follow-up
Vou deixar.
with this patient? I know. Can you bring the camera now to the femoral artery, please? Now we don't need more the angel in the screen, just
Okay.
the big screen in the room. Only the. Okay, great.
Deixa eu,
Thank you.
deixa eu,
Now we are going to finish that to see. We use only one per close. Let's see if it's possible.
Mesa tá solta. Deixa um pouquinho para baixo.
You are taking the
Mesa tá
sheet
solta.
out. Maybe can you describe what you're doing now, Dimitri or Alberto?
Yes, of course. I'm
Dá o
compressing the
trim, por
femoral
favor.
artery,
Takes a second.
and Dimitri will
Takes a second.
hold the tights that we did before the pre-closure technique.
Can you bring the camera close and to try to centralize that,
Deixa
please?
a mesa um pouco para
Okay,
lá,
great.
tá difícil de
Can you bring
comprimir
it
aqui.
a little bit down if it's possible, just to show? We're bring. Okay, great. Now we are moving the table. Okay,
So we have
let's
no
see.
bleeding with only one.
Only one per close,
Continua.
and take the
Deixa
wire.
eu ver.
Michelle is doing this, and we are going to do a little bit more compression, about 2 or 3 minutes, to see if it works. How about the pacemaker?
Tá bom.
The patient is awakened
Já tá indo.
after transvalve procedure. So are you do compression for 3 minutes?
And
Yeah.
we're gonna give some protamine, just a routine.
And Alberto, maybe we have maybe 4 minutes to go, 3 or 4 minutes to go. Could you describe the advantage to implant this valve over some other balloon
Não, é
expandable
muito
valves,
pequeno.
Okay, of
please?
course. Okay. In general, the results are really comparable. We can highlight the intermediate size and the possibility to remove the valve in case inability to cross the annulus or another structure. We have a really flexible delivery system, but we lose in pushability. And so I think it's pretty the same and the results are comparable.
Is there any limitation? Can you open the camera now in the room for the operators, please? Um, and is there any disadvantage in to implant this kind of valve, Alberto?
Yeah, I don't know. It is a disadvantage, but we have no mid and long-term follow-up.
Okay.
We need more results of clinical studies to see the results of long term.
Let me ask you one question, important question, Dimitri. To decide for a device for a patient, should he always look at the long-term follow-up of this?
Um, when we expand the indications for younger patients, I think it's crucial
Mm-hmm.
to have long-term data
Mm-hmm.
on TAVI. But if we are treating, for example, older patients, 85, like we did when we and we do nowadays, there are some older patients that we are treating. Um, it's not so important to
Uh,
have those data,
I
right?
see. So could you try to give us an explanation? And yeah, we are treating patients over 70 years old. It's really rare when you treat patients under 70. Uh, do you think are we ready to have the indication for those patients under 70? I mean, very low risk patients for surgery?
Yeah, it's a difficult decision when we are faced those patients. Generally, we tend to treat patients with high risk, younger patients, but with high risk for surgery. That's our experience here. Let's say patients with porcelain
Mm,
aorta or important
okay.
comorbidities.
Uh-huh.
But in the end, is a shared decision between the doctor and the patient, right?
Mhm.
We need to explain that we don't have data on durability,
Mm.
but we have to discuss in a hard team environment
Mhm.
and decide with the patient.
Okay. Great. So, Alberto, how are you doing with the? Can you bring the camera now to the femoral artery, please?
Yeah, I think we are
Over there.
done with the
Yes.
compression. We are done with the
We
compression.
are done with the compression with only one proglide.
Yeah.
So now is 11:44. So we have started 44 minutes ago. We had a prediction to finish this case in 45 minutes because we want to give you 15 um, more minutes to the other team, the coronary team that are working the next lab because we have a multi-vessel disease that we are going to present to you in the next minute. Do you have any additional comments?
I
Uh,
think it's a,
the patient is awakened. Tá acordando, Walter? Okay. The patient is almost awake now, and I think it's we finish. So it's our third structural uh, patient that we treat during this course in the 3 week course. The first we did the valve procedure, mitral. That was that spectacular case with 3 punctures in the septum. The second one was in last week, the very calcified valve
bicuspid
and
or
bicuspid,
bicuspid.
bicuspid. Then we treated, and now we treat. This is a very simple case that we do routinely. 81 years old lady, but with 88 kilograms, with CMI very high, she's obese, with small annulus, with a balloon expander, and also with a balloon rupture. And we saw how we managed that. So thank you, Dimitri. Thank you, Alberto.
Thank you.
And thank you, everyone who's watching us, the excellent team of nurse, Michele, anesthesiology, and also the echo. I'm moving to the next lab. See you in 3 or 4 minutes.